Thank you very much. Thank you for the introduction. And thank you also for the opportunity to speak today on Dispositivos and revascularización percutánea. And that is all the Spanish I will try to do today. I'm going to focus a bit our objectives on just the review of infrapopliteal disease, merely because of the time constraints. I want to do justice to the topic. And for that reason, I'm going to start with a review on the data regarding patency and limb salvage rates in infrapopliteal open surgical bypasses in patients with critical limb ischemia. Secondly, we'll review indications and techniques in performing aggressive endovascular below-the-knee therapies. And finally, we'll work to understand the limitations associated with these treatments for below-the-knee lesions. I'd like to also note that Dr. Al-Qaim at UT Houston helped me to put together these slides. As we all are very familiar with, CLTI is a limb-threatening pathology that has been correlated with exceedingly high amputation rates when prompt revascularization is not offered, a mortality rate of over 50% at 5 years after the diagnosis has been reported. Open surgical bypass in CLTI with autologous saphenous vein graft has been the gold standard in limb salvage for infrapopliteal occlusive disease that results in CLTI. More recently, though, essentially our best data sources are from the PREVENT-3 trial, which was quite a number of years ago now. Approximately 1,400 patients in this study were randomized to treatment with a novel molecular therapy to prevent vein graft failure in patients who underwent infrainguinal bypass for CLTI. This study found that the mortality associated with infrainguinal bypasses was less than 3%, and one-year limb salvage was 88%. However, among these 1,400 patients, 65% of the bypasses were to tibial and/or pedal or plantar vessels, but no separate analysis was done on this particular subgroup. So this study doesn't provide us with the benchmarks that we need for this group. Also in the landmark basal trial, only 10% of open bypasses were to infrapopliteal targets, providing even less data about outcome benchmarks for us. And while a slightly different group, this meta-analysis of distal origin grafts may provide some of the most useful data on their outcomes in the treatment of CLTI. As you can see, the primary graft patency at 5 years is about 63%, and the secondary patency is about 70%. Foot salvage rate is about 78% by 5 years. But in the same analysis, when they looked at bypasses to infrapopliteal arteries using conduits other than autogenous veins, the patency and foot preservation rates at 5 years were really poor. Autogenous conduit is absolutely necessary in order to ensure favorable outcomes. So this, in combination with other limitations to infrapopliteal bypass, are quite significant. There's high complication rates. There's the necessity for adequate autologous conduit. Generally, these procedures are only done to one target vessel, revascularizing only that one particular vessel, which may not be in the angiosome of the womb. In addition, these can be very technically demanding cases, especially when to an inframalleolar target. And medical suitability of the patient population varies quite substantially, as does patient preference for an open versus an endovascular procedure. It is because of these issues, as well as some others, that there's been push and interest in applying endovascular therapy to this anatomic location below the knee. As we have seen an overall shift towards endovascular treatment of PAD, rates of major lower extremity amputation have also trended down. And certainly I wouldn't say that this is necessarily a causal relationship, and many would argue that there have been other advances in podiatric care and medical management and access to care that may have driven this reduction in major amputations, but it's interesting nonetheless. So let's step back and consider the goals of revascularization. Essentially, we're looking to restore at least one straight line of blood flow to the ischemic foot, while also maintaining the patency of the treated artery for as long as possible, or at least as long as necessary to allow for ulcer healing, incisional healing, and pain relief. And I think there are a few things that have assisted in making infrapopliteal angioplasty the first line of treatment for many patients. We've come to a point where most providers would now say that this is first line. Historically, it was only considered in short stenotic lesions or for patients who were poor bypass candidates. But these particular things have helped to advance the role of endovascular therapy as the first line of treatment in CLTI. Essentially, there are finely dedicated materials and devices for this purpose. There are expanded options for accessing the lesion percutaneously. And third, there are just far more people now who can do a percutaneous intervention compared with those who can do an open bypass when you factor in the interventional radiology and interventional cardiology populations of providers. There are some other potential benefits, including lower procedural complication rates, comorbidities being less prohibitive as many of these cases are done under moderate sedation or even just with local anesthesia. There are several access options, as I mentioned. There's the ability to recanalize multiple native vessels as opposed to just one single target. These interventions can be done repeatedly, far more easily than repeat bypass. And some would argue that an endo-first strategy still maintains a bypass option down the road, although definitely that's a controversial position with a lot of controversial evidence against that. So is there data to support below the knee and below the ankle endovascular interventions? Well, really not, there isn't. We started this talk though with the quality of evidence for open, and basically the VAR is very low. And as we will see, the evidence for endo is perhaps even worse than that. There are certainly no RCTs, and the data mostly comes from single-arm retrospective studies of incredibly small cohorts of patients. The patients themselves are typically a mixed group of intermittent claudication in CLTI, which skews the data significantly, and long-term outcomes are essentially non-existent. This is a meta-analysis that compiled some of the best data to date. In a cohort isolated to CLTI, there were 30 studies between 1990 and 2006. While balloon angioplasty demonstrated poor primary patency, somehow limb salvage rates still remained as high as 80% at 3 years. This is essentially in line with what bypass outcomes are, despite the worse patency with endovascular approaches. Another propensity matched analysis between infrapopliteal angioplasty versus distal bypass demonstrated better patency for open bypass, but limb salvage was equivalent. The complication rate is much higher, of course, in the surgical bypass group than in the endovascular group. So let's just talk about the technique a little bit. It can be performed from the contralateral groin when targeting a lesion that's in the proximal 1 to 2/3 of the tibia. An antegrade ipsilateral approach is more favorable when a target is distal to that, as it does enhance the pushability of the wire. A 5 French or a 6 French sheath is typically required, and this usually has to be somewhere on the order of 30 to 60 centimeters in length, depending on whether it's antegrade or retrograde technique from the contra. The wire choice depends on the nature of the lesions. In cases of total occlusions, Confianza, Miracle Brothers, Command, and V18 are some of the most common choices. When it's not a total occlusion, a standard 014 or 018 wire, such as the Spartacore, Hydro ST, or Advantage Glide may be adequate. Chronic total occlusion support catheters include the CXI angled tip and the Quick Cross, the Navicross, the Rubicon, and the Trailblazer. They're all roughly equivalent, with really only the difference being whether they are angled at the tip or straight. The principles of crossing tibial lesions are analogous to that in the coronaries. Transluminal is always favored as it avoids excluding pedal vessels that have no collateral options. Subintimal is not ideal, but crossing techniques have been used successfully. The value of plantar flexion and dorsiflexion must be considered as well for taking those turns as the vessels enter the foot. It can be useful in terms of straightening out the vessel. But there are complications associated with infrapopliteal interventions. First off, as with any intervention, there's access-related complications that are possible. But what's unique to this work is that tibial arteries also tend to go into a bit more severe spasm. Intra-arterial vasodilators are sometimes required to help manage this situation. You can also cause perforation of the vessels, and it's significant in this case in terms of the fact that it often will result in a compartment syndrome if the bleeding is not well controlled. However, bleeding usually can be controlled with a prolonged insufflation at a low pressure, 5 minutes at about 5 atmospheres. So some words about retrograde pedal access. Studies have shown that the standard antegrade approach fails in up to 20% of patients. Endovascular innovations such as retrograde pedal access and transcollateral revascularization have been developed to help mitigate this. There's a lot of discussion back and forth about whether to use a sheath or not to use a sheath, but in brief, there are these micropuncture kits that are specifically designed for this. And the rationale for why it works is that branches and collaterals will tend to take off with a caudal angle. And so getting your wire in from below may actually allow for a better sort of trajectory, since there's not an alternative pathway that's easily available otherwise. The distal end of the stenoses is often thought to be softer than the proximal end as well. Percutaneous revascularization through a retrograde approach, again, uses this micropuncture introducer set. Typically, I like to use a hockey stick probe, as it better shows the very superficial vessels you see featured here, the posterior tibial artery deep to the two veins. Essentially, you just use this 21 gauge needle as you would with any other access and an 018 wire. And then, as I said, I do prefer to use the sheath, although that is somewhat controversial. The guide wire, once advanced, can then be snared by having access from an antegrade or from a retrograde up and over approach from the contralateral side. Through and through wire access is then achieved. Sometimes in heavily calcified vessels, you can end up in two separate subintimal planes, which may not connect. In these cases, the double balloon technique is one alternative to rescue the retrograde wire and to prevent propagation of the dissection plane. You inflate two opposing balloons, and the idea is essentially to disrupt the membrane that's separating them, thereby creating a channel. The pedal plantar loop technique is a technique that it is based on the creation of a loop from the dorsal to the plantar circulation, or vice versa. The goal is essentially to manage cases of where there are essentially no vessels in the foot, so-called desert foot, that is typical in diabetic and end-stage renal disease patients, where opening the distal distribution system, the plantar arch, becomes essential for wound healing. You can do this in two ways, either with an antegrade recanalization of the anterior tibial artery and pedal artery, including the plantar arch, followed by retrograde recanalization of the lateral plantar artery and then the posterior tibial artery, or with an antegrade recanalization of the posterior tibial artery and the lateral plantar artery, including the plantar arch, followed by retrograde recanalization of the pedal artery and then of the anterior tibial artery. This is an initial angio showing a patent PT with a lateral plantar branch and an incomplete pedal arch. An 014 wire you see being advanced successfully through the lateral plantar branch to the plantar arch, and then formation of the pedal loop. Ballooning of the pedal arch takes place next, usually with approximately a 2.5 millimeter balloon. Then the 014 wire can be snared, and a completion angio demonstrates now a patent pedal arch. There are some complication rates associated with pedal access, although the data from this tibial pedal registry of retrograde access shows a surprisingly low rate. Among 199 pedal access cases, there was one dissection, no thrombosis, and no compartment syndrome. So far, we have established that open surgical bypass is the gold standard with high primary patency, and it works well if you have a good vein and the right patient. Infrapopliteal balloon angioplasty has lower primary patency, but limb salvage is somehow reasonable when patients are not good enough candidates for an open procedure. Inframalleolar balloon angioplasty lacks data for or against its use. There are other endovascular techniques which are described. They've been proposed to improve the results of plain old angioplasty, and these include bare metal stents in the infrapopliteal segment, either balloon expandable or self-expanding, drug-eluting balloons or stents, cryoplasty, laser, and atherectomy. The data for all of these new technologies still derive predominantly from a few small RCTs and from retrospective case series with a limited number of patients and a relatively short clinical follow-up. It's very difficult to make any actual conclusions from these data. What we have sort of discerned is that in terms of below the knee stenting, stent use is common in the fempopliteal segment, and it also works well in the coronaries. So the concept made sense that it could be applied to the infrapopliteal segment. However, significant debate remains regarding the risk of stent fracture, restenosis, and thrombosis. Unlike the coronary arteries, there's less stress from motion in the infrapopliteal arteries, and stents are at risk of getting crushed. Early thrombosis and long-term patency are poor. Below the knee stenting is still limited to use as only a bailout technique, in my opinion, for flow-limiting dissections after intervention, restenosis and elastic recoil, and suboptimal endovascular results of balloon angioplasty alone. However, these results have to be interpreted with caution because these studies were very small in size and had very limited follow-up, and many were industry-sponsored. What about drug-eluting stents in below-the-knee lesions? In order to address this, there has been some evolution towards newer technologies, specifically patency-enhancing drug-coated devices. As reported earlier, bare metal stents showed little clinical advantage over successful balloon angioplasty in CLTI patients, and were really only used in cases of flow-limiting dissection or recoil. As the drug-eluting stent platform became established in the coronary bed, this encouraged acquisition of infrapopliteal data. This led to the performance of a few RCTs testing drug-eluting stents in below-the-knee lesions. The studies have been quite small, and they were industry-sponsored. They looked at a very short lesion length, approximately 10 centimeters, which is not really consistent with real-world practice. That all being said, they did show favorable rates as compared to bare metal stenting and just plain old balloon angioplasty. Majority of studies really have failed to sufficiently provide evidence that bare metal stenting or self-expanding stents are superior to angioplasty, so they are reserved for bailout treatment only. Drug-eluting stents in below-the-knee lesions have demonstrated better primary patency and limb salvage in RCTs that only looked at short lesions. This is not consistent with the real world and cannot be used to apply to practice. So the bottom line is that the stents that we use in the tibials were designed for coronaries and should be used for either bailout or only very focal lesions. In summary, there's terrible data for both open and endo. Open is probably best when single segment autogenous conduit is available, and endovascular approaches have not evolved beyond plain old balloon angioplasty. Further evidence is needed to move us forward in this realm, but there's absolutely the clinical need to do so at this point. Thank you.